Good afternoon all. I welcome you all to this WOW series webinar titled Cancer Pain and Palliative Care Up to Date. I welcome all the senior faculties from international and national forums, Dr. Sushma Bhatnagar, AIMS Delhi, Dr. Muralidhar Joshi, current ISA President from Hyderabad, Dr. Ram Pasupuleti, President, Kentucky Society of International Pain Practice USA, Dr. Carina and Dr.Ram, Director of Pain Medicine, Hong Kong University, Dr. Raghu S Thota, Professor, Department Onco Anesthesia and Palliative Medicine, Tata Memorial Hospital, and our host, Dr. Anand Murugesan, Clinical Head of Anesthesia, Department of Apollo Proton, Chennai. I now request Dr. Anand Murugesan to say a few words.
I welcome you all on the behalf of Department of Anesthesia, Pain and Palliative Care, Apollo Proton Cancer Centre to this wonderful webinar on Wednesday on cancer, pain and palliative care up to date. Apollo Proton Cancer Centre is an exclusive state-of-the-art JC accredited cancer hospital with proton facility and organ-specific cancer management team. It is my pride to submit here that we have a robust multidisciplinary pain and palliative care department of international standard. During this deadly pandemic period, almost the entire world came standstill, but still the cancer work continue and cannot stop. That's the reason we thought we should have an academic session on cancer, pain and palliative care to update our knowledge on the same. May I welcome Dr. Sushma Bhatnagar, Dr. Ram Pasupuleti, Dr. Muralidhar Joshi, Dr. Carina and Dr. Raghu S Thota to this webinar as a distinguished speaker. I welcome the management, Apollo management and other members of Apollo family to this webinar, and let's get the session started. Shruti?
I would like to introduce our first speaker for this session, Dr. Sushma Bhatnagar, who will be speaking on palliative care and why it should matter to us. She is currently the Professor and Head, Onco Anesthesia, Pain and Palliative Medicine, IRCH, All India Institute of Medical Sciences, New Delhi. She is also the founder, BM Onco Anesthesia and MD Palliative Medicine at AIMS Delhi. She is the principal investigator of sponsored research, ICMR, DRDO, AIMS, IITD, CSIR. She is the president, Indian Association of Palliative Care since 2018. She is also the chief editor, Indian Journal of Palliative Care since 2009. She has been the recipient of several global awards and has published more than 175 journals and has attended over 200 conferences. Over to you, ma'am.
Thank you very much. Just can you start, allow me to screen share, please? Yes. So can you see my slides?
Yes, ma'am.
Okay. So thank you very much, Anand, and thank you for the introduction. I'm really happy. Basically, I am in this forum because of Vethi and Madhurima. Madhurima, I can say proudly that she was my student and she was one of my bright student, and Vethi was also our student, but now he's a big surgeon, so I cannot call him a student. So they have asked me and they have requested me that Anand is working hard and developing onco anesthesia and palliative medicine, and you should be here. So that's why I am Anand. I know now you also, and I'm really happy and privileged to be here. And I really welcome Dr. Ram Pasupuleti, Dr. Muralidhar Joshi, and everybody is here. So I'm really happy to be in this gathering. So my talk is, Anand has asked me to talk about the palliative care. I just thought that when we were becoming doctor, when we were doing our MBBS and when we were doing our MD, we never used to hear the word palliative care or palliative medicine. And suddenly this word has popped up in our life since last 30 to 40 years. And recently, everywhere in the world, people wants to talk about palliative care, and it has become a word that if integration of palliative care is not there in any hospital, means there is no medical care in the hospital. So why it is exactly suddenly this word, why we have lost this word, and why it should matter to us why it should be there in all the hospitals, those who are treating patients. It's not only the cancer hospital, all other hospitals should also have this integration of concept of palliative care in their continuum of care. This is what I will speak in next 15 to 20 minutes. So this is my first slide, which we have seen, which we know that these are the various milestones as far as the progress in medicines are concerned. You know, we have started our medical science in 10,000 BC, where there used to be witch doctors, and witch doctors used to treat patients. And then all other invention came, sutures, eyeglasses, smallpox vaccination. In 1842, general anesthesia came, and then penicillin has been invented. But and all these landmark milestones, then landmark invention has created a huge impact on medical science and patient care as far as patient care is concerned. And finally, the recently, which these words we keep hearing: immunology, molecular biology, nanotechnology, robotics, and all these are again expensive but very, very unique invention, unique innovation in medical science, which has created and which has changed life of a patient drastically, and it is towards the better side. But however, do you think that all these invention has, whatever invention which we have created, whether it is, we should have an idea that whether it was worthwhile for the patient care, and we should have a balancing act. So there are positive side of all these invention, and all these positive sides I have narrated in 5 points. That as far as cancer is concerned, because this is a cancer hospital, so if we talked about cancer, what are the positive sides of medical innovation is that cancer has become, once upon a time, cancer and death, we used to think synonymous. If a patient is been diagnosed with cancer, we used to think that now he is going to die. But it's not like this. Now there are multiple cancers, those are curable. So cancer has become curable from incurable. Less invasive surgeries are in these days. There is no need to go for an extensive scar. There is no need to go for extensive pain, and people can have less invasive surgery. Then third point comes increased life expectancy. We can expect, if we have been diagnosed with cancer, we can expect, if it is incurable, then also we can have a good life expectancy and 5-year survival, because this has happened only because of innovation in medical science. Emerging pain modalities, and nowadays because of the invention in the pain modalities, we can 100% assure our patient that you are going to be pain free right from the perioperative period till the time advanced stage and in the terminal stage. Better drug profiles has really created innovation. It has really changed life expectancy of medical patients as far as their complications are concerned. So it is, they better drug profile are there, and patients are surviving more, and these are the positive side of therapeutics, medical therapeutics. What are the negative side? We have increased life expectancy, but we cannot deny that increased life expectancy many a time we are at the cost of growing complication, and we don't give any attention to the complication. So we are worried about the increased life expectancy, but we are ignoring the growing complication and also the recurrence rates. Second negative aspect is better drug profile, but at the cost of growing cost. We know that there are number of drugs available which has a better drug profile, and this can create which can improve the life expectancy from months to 6 months or 1 year, but at the cost of growing complication. If we will not at the growing cost, if we ignore about the cost, we are not bothered about the cost, and imagine if we dream that everything will be free of cost for all our patients and everything will be available for our patient. But the third important point is, if we are introducing new drugs, we are introducing new complications in the ICU. That is, most of the time, that most important complications are ventilatory associated pneumonias, ventilation associated problems. We put our patient in ICU, we use the better drugs, improved drugs, but we are also creating new complications like ventilatory associated pneumonias, which we are completely forgetting, and we start treating those patients. And then new drug resistant flora. In these days, the biggest problem in any of the critical care setup is ventilatory associated pneumonias and drug resistant flora, and we discuss a lot in all these critical conferences about this. And if we forget all these three aspects, then the fourth important point is person quality of life. We are targeting increased life expectancy, we are introducing better drugs, we are forgetting about the ventilator associated problems, and if at all, if we give quantity of life, we are just not concentrating quality of life, which is very, very important. You must have heard that all our grandparents used to always say that God give me the life which is very, and they used to say that Bhagwan mujhe utha lena agar main bistar pe aa jaun to. So this is what the quality of life is. Everybody wants that we should be healthy and hearty, we should be mobile, we should be able to do our daily activities, and this is we are completely forgetting in this medical innovation. And finally, we are not taking care of end of life. We already already India has been declared that India is the worst place to die, and I will come back to that slide, and why we have created this stage that India is becoming the worst place to die, because we are not taking care of a patient who is dying, and dying patient needs special care, and this should be considered as a medical care. And how we will consider this, I will come back to this. And then the major progress of therapeutics and major loss which I consider is loss of confidence between doctor and a patient. In these days, a patient who is suffering from a cancer, he will take at least 3 or 4 opinions, and he is not having confidence on faith on single doctors. Why we have lost that trust? Why there is no trust in healthcare system? This is because of too many inventions. I am not against invention. Inventions are good, but it should be judiciously we should use, and there should be a balancing behavior and act from a medical science and from a medical fraternity. So then we can develop a trust between a doctor and a patient again. This is a photograph which has come in the Bangladesh newspaper and on 14th June 2019. This is a photograph of a patient who has been undergone 25 operations since 2016. And he is suffering from a disease called, some skin disease called epidermodysplasia verrucosa, and he has undergone 25 operations in 2016. But see this, after 2016 in 2019, his condition is like this. And what he says in the newspaper cutting, that I cannot bear the pain anymore, I can't sleep at night, I asked the doctor to cut off my hand so I can at least get some relief. So imagine, everybody they were worried about that this should be removed, and they were doing their best. Then ultimately in 2019 on 24th June, he has given this statement that everything medical science has done, everything doctors have done, but I cannot bear this pain, and somebody should be there that who will chop off my hand so that I can at least be relieved from my pain. So what is the solution of this? I think all these problems which we have created, there is a solution which is called palliative care. What exactly the palliative care philosophy is, and this is again, we should not forget, when we were becoming a doctor, we have taken an oath that we will not treat a patient who cannot be cured. We will care that patient, but we will not treat that patient. But we have completely forgotten that oath, and that is what the reminder which palliative care gives us, that palliative care philosophy says that we should reduce the violence of a disease when disease cannot be cured. So disease is becoming violent, it cannot be cured, so we are going to take care of this patient by easing their symptoms, and we are not going to desert that patient, we are not going to 100% cure that disease, but we are going to take care of the patient by easing their symptoms. This is the philosophy of palliative medicine. There is another philosophy of palliative medicine which we can categorize into the 4 aspects. That palliative medicine, if we develop or we have an integrated palliative care program in any of the hospital, what hospital will do, they will affirm life. Life is very important. They will do their best to take care that patient should survive as long as possible, but they will regard dying as a normal process. So doctors and nurses, those who are working in this hospital, if they have an integrated palliative care program, they will consider that if diagnosis is our responsibility, treatment is our responsibility, then if patient is dying, then this is also our responsibility. So they will consider death as a normal process. If death is inevitable, they will consider that if patient is dying, they should provide end with dignity. So they will affirm life, but dying as a normal process. They will not be afraid of death, but they will treat the death by providing symptom management and giving a good end to the patient. Second important principle and goals of palliative care is promote quality of life. They will concentrate, everybody wants to concentrate quantity of life. We also want to live for 100 years, but we should not, we all want to live for 100 years, but not at the quality of life. So if an integrated palliative care program will be there in the hospital, they will also consider that quality of life is equally important, and it should not be at the quantity, should not be at the cost of quality. Then third point, which is very important, the hospital which have an integrated palliative care program, they will treat a person, not the disease. Treating disease is very important. Segregating hospital ward based on the disease parameter is very important, but ultimately we are treating a human being. So we should not forget a person, giving a holistic care of the patient. So whenever a patient is suffering with any disease, it's not only the cancer, even if a simple, I can say the viral fever, patient is having a lot of psychological and social problems, somebody should give them assurance that this can be cured or this cannot be cured. And then finally, support to the family. Family is also very important. We completely forget that when we are treating a patient, that family is also suffering with the patient simultaneously. What exactly the family member wants from a doctor, the doctor should give me the realistic hope and the correct diagnosis. So they want that somebody should give me the honest opinion and the realistic hope, that what is happening to my patient and what is the realistic hope of the treatment. Nobody wants, the family members, they are understanding that their patient is going down day by day. They don't want to listen from a doctor the false hope that you will be all right, I can cure you completely, because they understand that this is a lie. This is a doctor is not telling lie. But if you are going to give the realistic hope to the patient, they will understand, they will listen to you, and if you give the honest opinion about the treatment as well as about the disease, that will be a fantastic plan for the patient. And this is what the palliative medicine teaches us, that we should affirm life but regard dying as a normal process. Quantity is important, but quality is more important than quantity. We should treat a person because patient is ultimately a human being, and we should not forget that family member wants honest opinion and realistic hope. So if you have an integrated palliative care program in your hospital, you will be taking care of all these four aspects. What will be the positive outcome of the palliative medicine integration? That a lot of family meetings will happen, because all these things family may not understand in single meeting. There will be multiple family meetings. Then there will be a better understanding of diagnosis and prognosis, and we will allow patients and family member to make the informed choices, what exactly they want. So informed choices will be made by the patient and the family member, and ultimately there will be a better patient and physician relationship. The second question comes that who needs palliative care? It is always the cancer patient, those are privileged. I can say that all over the world, cancer patients are fortunate enough that they get at least palliative care. But there are multiple patients, those who needs palliative care. A patient with congestive heart failure who is coming to hospital at least 2 or 3 times in a week, he is getting repeatedly 3 times in 6 months he was in ICU. Again he come back to ICU. They are getting discharged again and again, but after discharge they cannot even go to the toilet. They cannot do their daily activities. All the medicines are failing day by day. A patient with a chronic renal failure patient who is getting dialyzed with 3 times in a week, still patient is puffy, patient is anemic, he cannot do their daily activities. Similarly, a patient with Alzheimer's and end-stage HIV/AIDS, similarly many neuro diseases like ALS, all these patients, they need palliative care, but unfortunately the whole world concentrate palliative care in terms of cancer patients. But ultimately in AIMS we have integrated not only the palliative care program cancer patients, but there is a dedicated integration of palliative care program in all the branches. Our palliative medicine residents, they are getting rotated in neuro, cardiac, pulmonary medicine, psychiatry, rehabilitation, nephrology, everywhere they are going in the emergency department, and they are spreading the concept of palliative medicine, and really end of life care plan has really changed all over them. So this is the way any hospital should integrate palliative medicine in various chronic diseases. This is just a glimpse of 1 year, 1 month, the 6 months the consultation which we have seen in all over the hospital. And you can see the pulmonary ENT, all the department, gynae, ortho, neurology, gastro, psychiatric, all these places we got the consultation in 6 months. And you know, the indication of consultation was 2 indications they have called us, either pain and symptom management, this I have told you, intractable pain and symptom management, or for end of life care. End of life care means patient is imminently dying, there is a need. I will come back to the slide that how you will handle the end of life care. So for these 2 things they have called us for various consultations. So this is just a figure of 6 months. I have figure of 20 years, but I have brought 6 months figure just to tell you that it's not only the cancer patient, there are multiple branches which needs integration of palliative care program in their day-to-day program. Then there is a magnitude of what is the magnitude of problem. This is the recent Lancet Commission report in 2018, which I was part of it. And then there's 61 million needs palliative care all over the country, world. And out of 61 million, more than 80% live in low and middle income countries. So imagine we come into this part, low and middle income countries, and India has a huge requirement, huge need of palliative care. And this is again the only India specific they have brought. And what they have said that all the patients, those who are having serious health related suffering, almost cancer patient 1.3 million, HIV/AIDS patient 1.9 million, 1.1 million, and because of the traumatic injury 0.95 million, they need palliative care in India. And now this is a figure from Global Atlas of Palliative Care in 2014. We keep on saying that cancer patient needs palliative care in group, in children. Children we completely neglect, we hardly take care of them, that they are in pain, and we think if at all, if there is an integrated palliative care program in children, it is only in cancer. But you can see that all other cancer is only 5.69%. Rest all, kidney disease, cirrhosis, congenital abnormalities, neonatal disease, protein allergy, malnutrition, meningitis, all these group of children, they need palliative care. So there is a huge demand, and it's a huge magnitude of problem is huge. And this is also a very important figure which we should never forget, that I told you that India is the worst place to die. How this sentence has come? This has come from 2015 Quality of Death Index, which this study was done by Lian Foundation, and they are now doing in 2021 they are doing another study that how India has improved. What they have found that India is on the 60th position out of 80 countries. They have done in 80 countries, they have done this study that what is the quality of death index, and India was on the 67th position. So the countries which were having good quality of death index were having integrated palliative care program, and UK comes number 1. So it means the people, though they have an integrated palliative care program and they have a good diagnostic facility, they have good treatment program, but if unfortunately if death is inevitable, if patient is dying from any chronic disease or chronic element, chronic serious health related disorders, they have a program that they allow person to die with dignity. So this is what is lacking in India. And this is again a very important slide, that palliative care is often misunderstood by end of life care. If at all, if palliative care program is there in various hospital, they think that if patient is dying, please send the patient to palliative care. This is absolutely wrong. This is palliative care should start from the beginning. And Vedi and Madhurima, they know that in AIMS, in cancer center especially, if a patient has been diagnosed and if they start treating, it's not that I'm telling that here palliative care physician should come. Palliative care need will be there. There should be integrated program, and even as soon as the patient has been diagnosed with even with a single metastasis, they start sending patient to immediately to palliative care program. So the patient start understanding that if a primary physician and oncologist is with me, the palliative care physician is also part of my treatment plan. And as the disease progresses, the palliative care take the leads, and ultimately when end of life care comes, the palliative care physician will be there, but primary physician will also be there. If at all, if we will send a patient at the end of when patient is dying, and we will send to the patient to the to palliative care, then patient will start thinking that they have sent me to the palliative care because I am going to die. But this is not the correct thing. Palliative care should integrate. There should be an integration of palliative care program from right from the beginning, and there are now ample evidence, and this has started with 2010 this paper in New England Journal of Medicine, that early integration of palliative care improves quality of life, as well as some type of little bit of quantity as well. So integration of palliative care right from the beginning really improves quality of life for a patient. This is just a growth of palliative care in India. In 1980, first hospice made in Mumbai. In 1990, NGO pioneered palliative care development has happened, and this was started. The movement has started from Calicut, and then the Can Support Delhi has come. Then the neighborhood network program in Kerala developed, and almost we have developed. But ultimately, whatever development has happened is primarily community based and NGO based. So still palliative care is basically community based or NGO based, and now there is a need to develop as an institution based, and that is what we are trying to develop, is a institutional based improvement, and we are trying to develop. Then there are various development has happened. Medical Council of India has recognized in 2010 palliative medicine as a separate specialty, but unfortunately 10 years have passed away. Only 3 institutes could start MD palliative medicine. NDPS Act has amended in 2014. This act says that all the patients, those who are suffering with cancer, should get opioids, and all the hospitals should have a clear-cut program, and they can get opioids for their patient. But unfortunately, less than 3% is still getting opioids. Then there, in 2019, ADCOM module has come. We all know attitude, communication, and ethics. We will teach our residents or our MBBS students, but the problem is who will teach. If we don't have an integrated, if we don't have a teachers to teach ADCOM module, who will teach to our patient, our students, attitude, communication, and ethics? So there is a need to develop integrated palliative care program throughout everywhere. So these are the steps to start. If any hospital wants to start palliative care program, they should have an establishment of outpatient services first. Then they should start consultative services. They should not demand that I should have 10 beds, 15 beds. Wherever the patient is, they should start consultative services, and automatically they will get a dedicated beds also. There should be uninterrupted supply of oral morphine to take care of cancer pain especially. They should have enough advocacy activities within the or outside organization, and there should be a dedicated palliative care physician as early as possible in your hospital, so that they can have they will be focused, and they will develop, and they will help you in development of palliative care program. Now there are enough MD palliative medicine from Tata Memorial Hospital, AIMS Hospital. We have already 8 MD palliative medicine has gone from AIMS. So there are enough MD palliative medicine physicians are available in the country. TMH already 5-6 years they are giving MD palliative medicine. Then now Gujarat Cancer Institute has started. So enough palliative medicine physicians are there. You should appoint palliative medicine physicians so that you can develop an integrated palliative care program. How will you convince your administration when you start palliative medicine program? This is again the same slide. Better patient and physician relationship by doing better understanding and making the informed choices. I have already told that by showing the positive outcomes of palliative care, even a single patient can create a lot of impact on your day to day, and by proving yourself every day that this we have made the difference in here, and so the administration will get definitely changed. These are the benefit of integration of palliative care. Definitely family and patients will be happy, they will be satisfied. Organization will have lot of advantage. It is not in terms of even the monetary advancement. The patient who does not need ICU care will be out in any of the room, and the patient who needs ICU care will be in, because otherwise there are limited beds of ICU. And the staff will also be satisfied, because staff, they know that extensively if we are giving care to a patient who is going to die and we are keeping that patient in ICU unnecessary for a month, it creates stress on the staff. This will be less with in the staff. This is a very important slide, that we should empower our nurses. We always underestimate our power of nursing. Whatever policies, pain policy we have created in AIMS, and life care policy we have created in AIMS, and it's a solid policy and it is all over the AIMS. It was failure till the time I realized that nursing power is the strongest power. So we have taught almost all nurses how to manage pain, how to give safe opioid use, how to take care of patient when patient is on opioids, how to take care of a patient who is dying imminently, how to handle the caregivers, how to talk to the patients and family members, because they are the one who are going to be there for 24 hours with the patient. So please don't underestimate the power of nurses. Please teach nurses first and then start having any policy which you want. This is our end of life care policy steps, that we recognize dying as a normal process. We give honest, accurate and early disclosure of prognosis to the family. We give proper communication with amongst physicians, supporting staff and patient and family member. Whenever all the consensus amongst caregivers, till the time everyone is on the same, not on the same page, we continue the treatment. Once the consensus amongst the caregivers are there, all the caregivers, means primary physician, palliative care physician, staff and patient family member, we document everything. There is no need to take signature, because many times we say that we will not going to put on ventilator when patient is gasping. They are not going to say yes for that time. So we have to start palliative care long time before patient becomes very sick. So when the consensus amongst all the caregivers are there, we document everything. We initiate the institutional supportive care protocol, and ultimately our aim is that we are not going to hasten death by giving something so that patient will die soon. We are not going to do that. We allow them to die naturally, but we are not going to postpone death by putting patient unnecessarily in ICU, by giving unnecessary vasopressors and putting patient. And at least I can say in cancer hospital, it is 100% coverage is there. We don't allow any patient to die unnecessary in ICU, which is big thing. And we have a very good program. All the oncologists sit together, we decide that this patient needs how much care, and we explain to the patient, and we maximum of our patients, they die at home. So this is my last slide, that most of us, we all want to die at home with our loved ones. Everybody, even if somebody will ask me that where you want to die, I will always say that my death is inevitable, I want to die with my loved one. But this does not happen. Most of our seniors, most of our professors, MLA, MPs, or VIPs, they die in ICU with all sorts of tubes and ventilators. So please create a system. If you will not create a system, tomorrow, if in IRCH, my death will be inevitable, my residents and my doctors, they know that I will not like to die in ICU, and they will allow me to die at home. So if you will not create a system, you all will die in the ICU. So please now create a system where you want to die. Otherwise, unknowingly, by default, everybody will be in ICU when the death will come. And this is again, we should teach humanity. As a doctor, I have completely forgotten the role of humanity, role of love and affection with the patient. It has 100% relief. There is no overdose, there is no underdose, and please use as much as possible. I can say that medical science is incomplete if we will not teach dying with dignity, role of humanity to our doctors, to our juniors, to our nurses. So teach and use humanity as much as possible. Thank you very much.
Thank you, ma'am, for that extremely empathetic and insightful talk on why palliative care should matter to us. Our next
Shruti, just a
speaker.
second. Thanks, ma'am, for your informative talk. And you really made things very clear, and you unfold the myths about myths and the misconception about the palliative care which is existing among the doctors and administration. So that's the reason you are here, and I really so proud to have you here and made all of us understand what is the concept of palliative care is about. Especially, I like your point on mentioning the task, the philosophy of the palliative care, which is not, the task is not just, if the task of medicine is to care, even if it cannot cure, that is the thing, that the point which you are taking from you, and about your point insisting upon the family meeting and the informed choices what we need to give to a end of life care patients, and the integration of the palliative care in the cancer pain management, and at the last, the empowering the nurses, the importance of the nurses in palliative care is the key of palliative care management. So we really take all these points from you, and thank you very much for your such a wonderful and informative talk. And thank you, ma'am.
Thank you very much.
Shruti.
Our next speaker is Dr. Muralidhar Joshi, who will be speaking to us on visceral pain in cancer, pathophysiology and its implication. He is the head of the Department of Anesthesia and Director, Pain Management Center, Ritchie Hospitals, Hyderabad. He is the current ISA President 2019 to 20. He was instrumental in starting the first Android application in the world on interventional pain management. He was also the first to start fellowship in pain management in India. He was the first to author a textbook of pain management in India, and he was also the first to start e-learning in pain management in India. He was awarded the Academic Excellence 2010 by Indian Society of Anesthesiologists. He has published 6 books and many articles. Over to you, sir.
I welcome you, Dr. Muralidhar Joshi, to this webinar on Wednesday.
Thank you, Anand. Anand, thanks a lot. Thanks a lot, man, joining all. Sorry, I joined a bit late because I was in another webinar. And thanks for the night's introduction and good lecture from Dr. Sushma, as ever. Without wasting much time, I would like to move on to the topic which asked me to share my thoughts on that one. And it's where I stand. Yeah. Anand, is it clear? Anand, is it here? Can you see the screen? Hello?
Yeah,
yes, Murali, we can see your screen.
Yeah, thank you. Thanks, Ram. Thanks a lot. Nice to hear your voice after a long time.
You are very much audible, Dr. Murali.
Yeah, thank you, Anand. Thank you, Ram. This is about cancer related to viscera and all that. I think it's an extension of what Dr. Sushma was discussing about how compassionate are you about handling this group of patients. I think this one particular slide, which I'm going to show it next, will explain to you the whole story about that one. Like this is how probably we might be seeing our outpatients so often and all those things. Patients coming to the hospital, of course, it may not be Ram, it may not be comfortable with this one. But the question is like, you have so many people coming for chemo, radiation, and then maybe post-surgical or maybe pre-surgical or palliative care, and it goes like that. But question, one thing we should not forget about at any point of time is, just look at this picture. If you just focus on that, the plus point in the center, and keep focusing that, you'll see that the pink dots which are moving, suddenly they become, you'll see a single dot which is green. Anand, I'm relying on you. Focus the plus, the center point plus. At some point in time, like all the pink dots will disappear, only green dot will be moving. Am I right? So if you just look at it, basically what I was trying to impress on, like whenever a patient who has a malignancy or something like that, when they come with probably different kind of situations, could be emotional aspect, could be physical aspect, or the financial aspect, or maybe they had to go for surgery or chemo radiation. If you keep on focusing at the patient, more of a holistic approach, you'll be able to see the same person is moving to different dots. The problem is same, but he'll keep on moving to different dots and trying to connect the different sectors and all. In the process, he tends to like get lost in the whole process and all. And what was his so-called physical pain or something and all adds to more to emotional disturbance and a lot of other things which is not pleasant for anybody to understand. Comes to visceral pain as such, actually, when we say about viscera, it's nothing but the organs which are enclosed within the body cavities as such. The pain results from activation of the pain receptors by invasion, infiltration, extension, compression, or a stretch of viscera. The solid viscera like lungs, liver, kidney are maybe quite insensitive to destruction unless the capsular invasion happens. This is very important for us to understand how the visceral pain comes in, especially solid viscera. Somebody having secondaries in liver, it might be just sitting there unless the capsular invasion doesn't happen. This is what we have to understand. When it happens, then you start feeling secondary pain. And subsequent with hollow viscera, again, colon also sensitive to stretch or distension. But if something is growing above the surface of the colon, again, patient won't feel the pain. So these are some of the things which are visceral pain slightly different from the so-called like a somatic pain. I'll just share with you like about a case report as such. You can just imagine a 66-year-old made diagnosed with pancreatic malignancy in advanced stage and has received the chemotherapy and is suffering from unrelieved abdominal pain related to the back, was on opioids, NSAIDs, and pain modulators, of course, so without much relief and all. And he was diagnosed as CA head of pancreas to pancreatic. You can just see over this is what we call the chain of plaques. Here, this is a malignancy, what you are looking over here, and also has some kind of secondaries over here. But the question was because all the methods were tried, considered like opiates were tried, NSAIDs were tried, and other medication, chemo or whatever could have been, surgery has been tried. He was offered celiac plus neurolysis, and the CT guided approach was considered because of the imaging comfort zone, because you can delineate the soft tissue and other things. And it was planned in the classic retroclear approach, and needles inserted bilaterally, and almost 10 ml of 70% alcohol injected on either side, and patient had good relief. But this is how the probably the celiac plus block looks. Probably more information will be shared by Dr. Anand when he's going to discuss about interventions and all those things. These are needles what you are going to see over here, something like this. Maybe it's up around the junction of T11, T12 and all those things. So the needles come from either side. This is the retroclear approach. You can see the crust of diaphragm coming here. This is the aorta. Needles coming here. If you just look at needles over here, we inject some amount of contrast over here. Post contrast, you can just see the the neurotic solution stays in a gutter like this. And it's more like an celiac plus block neurolysis. Some people go in the anterior approach for what you call it as a probably celiac plus block over here. Some of us might come to transaortic. There are almost 8 to 10 approaches are there. Either way, as long as patient can get a good relief with any of these things. The reason why the celiac plus block will be considered this group of patients is visceral pain is because opiates can give relief up to 60%, 60 to 70%, they can give good relief. But anything more than that, it's difficult for the opiates to give the relief. They really depend on some of these kind of interventions. Though normally we don't recommend intervention many of the cancer patients, but these are visceral pains, some of the exceptions where you might have to consider these things because we don't have medication to take care of the visceral pain that easily. Though we have some of the antispasmodics and all, but beyond a limit, they find it difficult to to offer the same good relief as such. What you can think about it. The most important one has to understand visceral pain, especially for many of the what you see about this malignancies and all. The receptors always will be there. You can call them high threshold and low threshold receptors. But one thing is they'll be silent, but they get activated if the local ischemia because the tumor probably grows into and interrupts with the blood supply to that area, and hypoxia against some oxygenation won't happen. Some local inflammation can activate all the silent receptors. That's one thing. Sometimes there can be triggering factors like which may not be linked to tissue injury, but nature provoking stimulus. As I was telling colon, the descending intraluminal pressure rather than the volume. Just again repeat the question again. I'll repeat again same point here. The descending intraluminal pressure contributes to the pain rather than the volume. Again, extraluminal growth delays destruction. Solid organs, the least sensitive till the capsular invasion doesn't happen. So this is where you might sometimes, some of the maybe about some cancer patient might present you with like a pain as the first symptom, but by then it will be much more advanced stage compared to the many other features as such. So how does this visceral pain get conducted to the spinal cord or maybe central system and all? The visceral sensory information through sympathetic and parasympathetic chain goes to the dorsal horn through lamina 1 and 5 it go to visual-somatic and visual-visual convergence. And sometimes you might get referred pain, something like, we always talk about maybe cancer liver, all this irritating the diaphragm, it can go towards the probably shoulder and all those things, which you're all aware of this one, referred pain. We call it as convergence and projection theory, and it can lead to some amount of central sensitization and maybe to continuous input. The visceral pain features are slightly different from compared to the somatic pain as such, because they can present like aches or maybe some cramps here, like they say, sometimes they squash stomach kind of thing, or sometimes they say I feel that my intestine getting twisted and all those. The wordings might be differ from place to place, people to people, and again to the situation as such. And it can be diffuse pain, can be poorly localized and referred to the nearby non-visual structures. And sometimes that might similar to autonomic reflexes, which might present like nausea, and it can sometimes combine with somatic or neuropathic pain. You never know. So we always combine visceral pain problems along with some amount of medication for the anti-neuropathic pain medication also, because there can be a component of neuropathic pain in this group of patients. The treatment options for the visceral pain, it's usually a multidisciplinary approach. Most people treat the cause. If you can take out the tumor, nothing like it. But it happens so often, it may not be that easy to do that one. Second option might be to increase the pain threshold. And you have the medical option, like pharmacological options, something like opioids, NSAIDs, and pain modulators like TCS or anticonvulsants. Sometimes we do use non-pharmacological approach like physical therapy and the cognitive and behavioral therapy, because we need to overcome probably whatever things which are there. And of course, third and the last one comes to interrupting the nociceptive pathway to allow the superior analgesia and reduce the opioid consumption. Interventions might vary from institution to institution and then clinician to clinician, depending on the variable level of competency and expertise. It may start with administration local anesthetics if somebody is not comfortable about handling with the neuroleptics and all. Somebody might use opioids along with local anesthetics. Somebody might neuroleptics to give laxation.
And you give the other thing free because they've already paid $75 for consultation.
Can you
How justified are you? We can't.
Anand, can you mute other people, please? If you don't mind.
Hello, somebody's phone. Yeah, Stewart sir. Okay. Sorry for the interruption.
No, it's okay, Anand. We'll move on. Don't worry. So we can do the interventions, but if somebody is not comfortable handling the neuroleptics or something else, it's understandable because technical expertise may not be available at all places. Some competency might vary. You might try administration local anesthetics with opioids, and neuroleptics can be used for neuroaxial visual plexi and all. Sometimes we use the neurosurgical thing option like application, only thing limited to survival of cancer patient and all, percutaneous cordotomy and all those things. Often we offer for some of the CA lung patients and all, but again, everything boils down to the competency and the survival duration of the, I should say, the patient as such, because at least there should be survival rate of at least about 3 months for if you to offer certain things. But nobody knows how long anybody can live, but you can keep the person comfortable as long. But higher invasive things, or implants and all, at least we normally look for at least there should be 3 months of survival rate. Otherwise, it may not offer the much benefit. That's the only, doesn't mean that we should not be doing it and all. So these are some of the interventions which we look at it from the visceral, like how the foregut, midgut, and hindgut evolved over course of time. Usually we offer celiac neurolysis for the pain arising secondary to malignancies from liver, spleen, pancreas, kidney, suprarenal glands, to 2/3 of transfusion. Almost you can say about all the midgut organs, we can apply celiac plexus block, and of course little bit hindgut and all those you can go for the superior hypogastric plexus neurolysis like pelvic pain and tumor invasion and all. Ganglion impaired neurolysis is good for the perineal pain due to pelvic cancer, and of course Cochrane review for all these things. Still, some of them are protocol stage, some are advanced and all. Still things are going on. If you look at the celiac plexus neurolysis as such, there is 85% success rate across all studies. 85, that's a big number, 85% success rate across all studies. It alleviates pain immediately in almost 70 to 80% of patients and 60 to 65% till the time of death. That's what we understand. The results will be best when pain still responds to anti-inflammatory drugs and all, and it's ineffective in advanced proliferative stage of tumor. The reason being the lymph nodes might be around celiac axis. Even though you deposit neurotic substance over there, it may not reach the plexus. The plexus might have distorted, or the lymph nodes might be obstructing the flow of the medication, and maybe the tumor itself might be invading the whole area. Coming to the other one which offer for the visceral pain is superior hypergastric neurolysis. That's a pelvic pain due to the pelvic malignancy as such. Less complications when compared with the intrathecal neurolysis, where the risk of bowel and bladder dysfunction can happen, but less effective if extensive retroperitoneal nodes are encompassing the neural plexus. Again, if neural plexus get encompassed with the lymph nodes or the tumor, then again you won't get much benefit out of it. Less pain relief if tumor invades somatic or neural elements, but of course, so no control studies as such at this stage. So some of the pictures of the superior hypergastric plexus neurolysis. You can see plexus over here, and again same thing. This is the alpha S1 junction over here. This is where probably the iliac vessels are there, and you can see the plexus over here. This gutter, the needle coming from here, contrast from both the sides. You can see the retroperitoneal spread of all this whole contrast neural substance here. So of course, this patient already had the colostomy kind of thing, so not a much problem as such. One of the youngest interventions I should say about this is the ganglion for neurolysis, called as ganglion of Walther, and the procedure reported for the first time sometime in 1990 as such. Perennial pain due to pelvic malignancy, especially the prostatic cancer, vulval malignancy, or these kind of things which are there in that perennial area, it really works well. Local tumor spread can limit the spread of neurotics, but again, the same difficulty as controlled studies as such. It's quite simple. Like it can just look like this. Like if you just look at if this is the sacrum, what you're seeing, this is the bowel guy shadow in the rectum and all. Like it looks like a goblet kind of thing over here. And the different techniques are described as such. You can put the needle like this and all. But what we do these days, we just go from a sacrococcygeal junction, put a needle here, inject neural substance over it, goes over here, and it does a good job. And it can be repeated. You can do it fluoroscopically or maybe ultrasound guide also. It's not a problem as such. It's one of the rare blocks. What do we do for visceral sympatholysis, thoracic sympatholysis? That's what we say. You can just look at over here. This is one of the patient who had the CFS secondaries in the pleural and all those things, and we had to put a needle over here. You just see here, and some contrast being injected over here. This is all okay. This was his lung was normal. The opposite we had the pleural effusion, and the patient had good relief as long as she was living. So this is a bit complicated, but you need to use for this thing more of imaging assistance as such, because to avoid a secondary complication in a patient who already has his own problems. So what are the limitation of many of these neurolysis? It's important to know. Most important, we should be looking for what should be the meaningful expectation. What exactly a patient expects, what you communicate. At times people say, you inject one this thing, it will go up. But again, if somebody you do for something celiac plexus block, tomorrow patient develops secondaries somewhere in the brain, or sometimes in the spine, as here and there, then that may not offer the relief. So that's what we have to make them realize. It takes care of only upper abdominal pain only. That's what we have to say. And earlier the better. The most important difficult thing is the technical skill availability. You can get short-term relief in some of these places where there are some technical shortcomings, so that people might use local anesthetic. You might get some short-term relief. Sometimes tumor or celiac plexus block, plexus, again may not allow the neural solution to spread. Presence of mets over the plexus, somatic pain second to significant peritoneal involvement. These are situations where you may not get a good relief, especially advanced stage and all those things. It's very difficult to get good results. What advantage neurolysis, if you just look at it, visceral pain in cancer patients can be best managed by a combination of analgesics and interventions. Non-analgesic benefits can be like limitation of side effects, improved quality of life, improved weight gain, less sedated, more alert, satisfied patients. Repeat block may be needed with increased survival. These are some of the things which advanced things which I think Anand might be speaking on that one. It's about intrathecal drug delivery systems and all. We can load morphine this particular pump, and then you can just put it with a catheter intrathecally. That release morphine at a controlled fashion, and that should take, because sometimes we give oral opiates. I think Dr. Ram is going to speak on that one. Sometimes it may not be comfortable for the patient because side effect might be more, but this takes care of that one. Little bit cost factor we have in India for this one, but anybody who can live for at least who knows who can live fitness live for at least more than 3 months, this can be offered definitely much better than compared to many other procedures as such. So to summarize, I would like to say a combination of medications and interventions should be the best. A meaningful expectation is most important. Earlier the better. Advanced proliferative stage may not provide good relief, and if needed, repeat intervention can be tried. But most important thing is imaging assistance offers safety and accuracy. Always please use imaging assistance. Don't try to do it blind or with a surface landmark. I think I'll stop at this stage. Thank you, one and all for patient listening. Thank you very much.
Am I audible?
Yeah, please.
Thanks for your fine speech, Dr. Murali. Really, we got a lot of points to know from your talk. What I impressed was about the point what you mentioned, that distending the intraluminal pressure is more important than the volume. That is something like, which means like you need not, the tumor need not be so big, for the pain. It's not proportionate to the volume of the tumor. It can be even small, but it's the intraluminal pressure that is causing, that is more significant, important than your volume of the tumor. That is really a point to be taken. And I also have got a couple of questions to you, Dr. Murali.
Sure.
Regarding the repeated blocks, what you have mentioned, in your experience, like how often we will come across, and how often we can repeat this neurolytic blocks in visceral pain?
Yeah, Anand, that's as Anand rightly said. I would like to say most important is it's not that can be repeated or something like that. It can repeat it, but it's not. I should say it's not possible because there are times, because normally these blocks, see, nothing is permanent. That the effect and side effect, nothing is permanent. So normally these blocks are expected to work for 8 to 9 months, 7 to 8, 9 months, something like that. If somebody has a slow growing tumor and is comforted in 8 months, again it comes back, you can always offer a second shot for the same thing. But most important is dermatomally, we need to be clear about that, which part of the gut, or foregut, midgut, hindgut. If you have a clarity in that one, invariably able to do a good job, and it'll be clear. And imaging is most important, because there was a time when I used to do with the fluoroscopy. Nothing wrong, you can do with fluoroscopy now, also nothing wrong about it. But I found it much easier to, because the time people come with old CT scan, which might be for 3 or 4 months earlier, and you go fluoroscopy, in these 3-4 months, maybe patient might have his own mets already. So when you go for a CT view and all those, you can see lymph nodes where all they are. Then you can decide that you want to go for anterior, posterior, a lot of things. Rather going for one more CT and doing and all. And there are times it happens. Normally, what I discovered, one procedure was the prone position, retroculate for celiac plexus block. Sometimes if the patient cannot lie down prone because he got ascites or maybe severe pain or big tumor, we go for a lateral. We go for one side. We go one side and inject over 20 ml of volume, then do it. And there are times I have to do anterior also. But I stopped doing that sometimes because a lot of people used to have lymph nodes having big mass and all. I think everything boils down to the skill of the person who is doing it. But if somebody serves 8-9 months, invariably they might have to go for second shot if they're keen about it.
And my second question is, like, these days I see interventional pain specialists, they add superior hypogastric blocks along with celiac plexus block, even for an upper abdominal malignancy, because like there may be a component of iliac lymph nodes or peritoneal or mesenteric lymph nodes in the lower abdomen as well. So, and there are few studies also published in Chinese journals, like supplementing the superior hypogastric ablation along with the celiac ganglion, celiac plexus block, even for upper abdominal malignancy. So what's your take on that?
What we have to understand, what stage of the malignancy he has presented to you. Was it early stage? If it's only upper abdominal malignancy, they're not, see, I'm telling you again, these blocks, maximum I'm expecting 8 to 9 months. This lasts my 25 years experience, not more than that. If there are no secondaries in the mesenteric and all, there's no prophylactic block. You got a point, Anand?
Yeah.
There's no prophylactic block. If you think upper abdomen, if lymph nodes are there, you think there could be like visceral pain. But again, I'm telling you, don't underestimate the role of anti-neuropathic pain medications. They do take care of this visceral pain. Because what happens if you don't diagnose, see, there could be lymph nodes which are inflammatory, there are some lymph nodes which are mitotic lesion. So there you have when you read about PET CT and all those things, you should have an idea about what kind of lesions are you looking at it, or you can talk to your nuclear medicine person or maybe the radiologist about this particular one. What kind of lesions? Doing it both, it's nothing wrong about that particular process as such and all. Not that it's not be done, but your clarity about what you're doing is very important. Like rather than blindly doing all 3 blocks at one go, celiac plus a block, hypergastric, and even doing the ganglion impart block, that won't help us. See, something like doing so many blocks at one go. When there is no need. Inflammatory or even lymph nodes are different compared to mitotic lesions. So we have to understand what exactly we're handling.
Okay.
And
And
technically, both can at the same prone position, they can be done. One may be at L1 T12 level, other can be at maybe alpha S1 level.
Okay. And one last question from my side. And regarding the head and neck cancers, like what will be the intervention of choice in head and neck visceral pain? How head and neck cancers are different from other visceral cancer pain?
Head and neck malignancy is slightly different because what happens, whatever visceral flow, what you see about sympathetic and all those things, literally it almost starts from the T6, T7 level, they descend downwards. But for head and neck, actually, almost they climb up towards the stellate ganglion and all those things. And 2 groups are there. One, some of this head and neck malignancy, I usually keep, especially lymphomas and all, I keep on doing the stellate ganglion block is one more thing. Sometimes I do the sphenoparietal ganglion block. Sometimes peripheral division block. See what happens, sometimes you break the pain, spasm, pain cycle, that itself gives a lot of relief. Sometimes there'll be, I should say, oropharyngeal malignancies. You feel like doing probably trigeminal and all, but often it's invading that whole area. You might be inoculating probably the bacterial infection all the way from skin up to the Meckel's cave. So you should be careful about how you select all these things. In case you feel the malignancy, there could be a reason. Then you can always consider probably the peripheral branch division, even if you have to repeat little bit. Sometimes I adopt if the risk is too high. Sometimes I put a catheter over there, give the local, because I was stay for a couple of weeks at the hospital for radiation or chemo and all. I inject local anesthetics, or I teach the family member or maybe the doctor who is handling them. So use various combinations depending on education status of the patient and whether he can stay in the probably at my hospital or outside or where he is going to go. But sometimes the peripheral blocks also do it. And most important is, as the Dr. Sushma was also mentioning, educating our own healthcare workers, doctors, nurses, or maybe as a support team. It matters a lot. It matters a lot. Sometimes there could be a patient family who can take care of this much better.
Okay. So I think any questions from anyone for Dr. Murali before we move to our next speaker?
Sir.
Hello.
Yeah, please go ahead.
Yes, sir. Please go ahead.
Dr. Arvind? So he got disconnected.
One question from me.
Yes, Dr. G.S. Anand Kumar.
Yeah, Dr. Anand.
Yeah, Anand, how are you? Long time.
Sir, fine, sir. How are you, sir?
Yeah, all good, Anand. Long time to hear from you, man. Nice seeing you.
Really very happy to see you.
Yeah, same thing here. I know all of us have lost 4-5 months.
Ram, sir, everyone. I'm really very happy to see you. Sir, what about this prophylactic block, sir? First time I'm hearing actually. Because since Anand Murugesan asked you that regarding this combinations of superior hypogastric block.
Actually, it happens sometimes. Very much right. Actually, really I tell you. Sorry?
It is really useful for doing.
No, I was just explaining to how why it happens is what I'm trying to say. I was not telling that somebody should be doing it. Why it happens is, see, sometimes reporting comes like that from probably the nuclear medicine team says, for example, they'll say metabolic nodes active in celiac axis and close to the alpha S1 area, maybe the hypergastric area. Metabolical active is one thing. A second thing, convincing a patient to go for a second block maybe a few weeks later is a bit difficult. Usually, what I do is my way of approach. Maybe somebody can better. Usually, I start them with a couple of weeks of neuropathic pain medication, anti-neuropathic pain medication. See how much symptoms are improved and all. And I rarely done. Rather, I almost have not done only 1 or 2 cases. Maybe celiac pluses. Maybe subsequently later, probably 8-9 months down when he came with lymph nodes and all. Same setting, doing both for celiac and hypergastric, I have not done because I have not come across that kind of patient. If somebody has
I've
come
read
across,
your book, sir. Actually, you have never mentioned in anywhere. I've read your textbook actually.
no, that's what I'm trying to say. I have not, I had maybe once or twice. I'm not in, once or twice in celiac. Like I do celiac plus block now. Maybe 8 months down, there comes secondary in hypergastric area. Maybe I might repeat it. Same sitting, almost no, I have not done. But usually, what I adopt these days is I usually start with anti-neuropathic pain medication. Wait for a couple of weeks and see how much symptoms have improved for him.
Okay.
Like already, see what most of our common like our own oncology team would have started them on some opiates or whatever medication they feel appropriate. And depending on leftover, so my job is to hand over the leftover pain, then whatever has been managed. So there, what happened, my part, but rarely I had done so-called what is like 2 blocks. I rarely require. The only thing is probably in case somebody encountered, I don't know, because you don't know how the things keep on evolving. It's not in our control. But rarely, but in case somebody has lymph nodes at the celiac axis and also mesenteric, that definitely the high chances that they must be having the peritoneal mets also. Even if you do 2 blocks also, it may not help. Then you look at which is predominant pain. Predominant pain, you go for that one. The other one, medications.
Okay.
But I have not done same sitting both the blocks, Anand. I have not done.
Okay, sir. Okay. Thank you, sir. Thank you very much.
Sure, Anand. But nice meeting you, man. Hope to meet again soon.
Yes, sir. I am very happy to see
Dr.
you.
GS for contributing. Please stay with us till the webinar gets over and give your inputs, Dr. GS Anandakumar.
Sure.
So let's move on to the next speaker. Over to Shruti.
Thank you, Anand. Thank you so much.
Yeah, you're welcome.
Our next speaker is Dr. Raghu Thota, who will be speaking on post-chemo radiotherapy pain overview. Over to you, sir. He was instrumental in...
Dr. Raghu, you there?
Yeah.
Yeah, go ahead.
Just a minute. It's just that the screen sharing is...
No, don't worry. I'll introduce Raghu Thota. Raghu, will you mind if I introduce you?
Yeah, no problem, sir. It's honor.
Raghu S Thota is a senior faculty member at Tata Cancer Hospital and been there for quite some time over there. And he happens to be the onco anesthesia team. Raghu, are you the president right now or still secretary, honor secretary?
Secretary.
Don't stay there. You don't become old too early.
Yeah.
And it's published the guidelines for the, I should say, about the cancer pain and all through ISSP and also IASP. And very lively person, lot of active work he has done and a lot of work like TMH does, like Tata Memorial Hospital does, and we're proud to have Raghu over here. Sorry, Anand, but to barging in like this, but it doesn't matter. No? Let's move on with life.
Yeah. Thank you, sir. Thank you very much. So I will be speaking. Am I audible to all? Am I audible?
Yes, Raghu, go on.
Yeah.
You can go ahead. You can see the slides.
I will be talking about the post-chemotherapy and radiotherapy pain. It's a little out of the way topic, mainly because most of the patients are managed by the chemo-oncologists as well as the radiation oncologists. So these are the side effects or the sequelae of the ongoing active therapy for the cancer disease itself. So there are certain things which do happen to the patients which are not managed by them, by the oncologists, and then these patients are referred to us. And these are really too catastrophic, or not catastrophic, I will say, too moribund morbidities of these ongoing therapies. So there are many things to be talking about the post-chemotherapy and radiotherapy pain, but I will be speaking about a few things only because of the time constraint. So coming to the chemotherapy related pain. So as everyone knows that chemotherapy medications, these are the medications usually are toxic to the areas of the body with high mitotic index. So where there is a huge multiplication or generation of the cells, these medications act over there. So in a normal person, it is at the bone marrow and the epithelium of the gastrointestinal tracts, and in a cancer patient, it is the cancer cells. So they go and affect those cells and they destroy the cells, and that is how we get a good positive outcome in this patient. But at the same time, since it affects the normal cells also, we get certain sequelae and side effects. And the most commonest sequelae or the side effect which we encounter with chemotherapy is the oral mucositis. Though it is a mucositis, almost it happens in 40% of the patients, but the most presenting symptom or the primary symptom of mucositis is pain. Because of the pain due to swallowing, the patient is not able to have nutrition, have a food intake, oral intake. You can't even swallow his saliva. So it is such a debilitating condition. So these are the following chemotherapy related pain syndromes. They are related to the infusion and they are related to the toxicity of the drug itself. So we are not going to talk much about the infusion related chemotherapy related pain, but mostly we will be concentrating on the toxicity related pain, and that is the peripheral neuropathy, which is rampant and very common, especially in patients who are receiving taxanes and vincristine group of chemotherapeutic agents. Then oral mucositis, yes, definitely most of the chemotherapeutic agents do cause oral mucositis. We will be talking about that, and a few words about arthralgia and myalgia. I think you should be knowing, you should know this arthralgia. So we won't be talking other than this for the chemotherapy. Coming to the radiation-induced pain, so it is mainly because of the reactive oxygen species, that is ROS we call it as, and it keeps on compounding at the cellular level, and because of which there is a stress, oxidative stress at the cellular level, which damages the mitochondria, and at the nuclear level it damages your chromosomal levels and all. So because of which there is a destruction of the cell. Also, the local cellular signaling from the irradiated cells also produce increased cellular stress on the non-irradiated adjacents. There is something called as radiation-induced bystander effects. So those cells which are not irradiated are also affected by the irradiated cells. So this is something called as radiation-induced bystander effects. So this is something which we all should know. And in the forthcoming slides, we will speak about those things. And these are the radiation-induced pain syndromes which we will be encountering. And the commonest things which we will be speaking about now are the plexopathies and the peripheral nerve entrapments, osteoradionecrosis, as well as mucositis, oral mucositis. So oral mucositis, we will be speaking in combination of both chemotherapy related as well as radiotherapy related mucositis. Small slide, I just wanted to know that there is something called as a total dose of radiation which we give to the patients, either in the form of fractionations or either in the form of single fraction or a single dose. And there is a dose. The dose is that the energy of the joules which we give to the patient and his area which is exposed. So that is how the grays, this is the total dose, gray is calculated. So if you give around 30 to 40, the patients around the chest wall areas, you may have developed chest wall pain. If you are giving it to the oral areas, and if the dose is up to 40 to 45, you can have oral mucositis, and likely as the dose increases, you may have major injuries. Like if you are going up to 70 to 80 gray doses, then you may have rectal injury also. So coming to CIPN, that is the chemotherapy-induced peripheral neuropathy. So this is what we will be talking about much. And if you see, the prevalence rate of the CIPN is almost 68% in the first month of initiating the chemotherapy itself. So the peripheral neuropathy, the chemotherapy-induced, sometimes it may be acute, too acute also. It's not that it may initiate at the later stage, but at the same time, sometimes in some patients, they immediately show the symptoms in the form of motor weaknesses and all, and some patients may show the symptoms in a very delayed fashion. And at the end of 6 months, almost 30% of the patients do have CIPN. So why it is important that CIPN? Okay, because it leads to dose reduction, because the patient's quality of life is decreased. That is what we always talk about. Even Sushma madam was also talking about quality of life. Muralidhar sir was also talking about quality of life. So this matters the most. What we can do as a pain physician is that we can at least give a good quality of life to the patients. So this is should be our primary aim. So if the quality of the life of the patient is hampered, so the patient is reluctant to take this medication. So it leads to either just you will say that I just don't want to take the chemotherapy further, or if there are severe, very severe side effects of CIPN, then the medical oncologist may reduce the dose, or they may change the chemotherapy protocols. So the first line protocols may go down to the fourth line protocols, which may not be that effective in treating the cancer, or there may be a termination of the therapeutic agent. And predominantly, most of the CIPN is a sensory neuropathy, though it also affects motor as well as autonomic. So if you see this paper which has been published It's a systematic review critical analysis, and it shares that almost 40% of the patients do have this disability. And these are the chemotherapies group of drugs which cause peripheral neuropathy. And if you see, the vincristine and the bortezomib affect the autonomic component, and all other medications affect only the sensory and the motor. But mainly it is the sensory component which it is affected. Coming to the pathophysiology, so how does it causes? So what happens is that axon is there, okay, and the dendrite is there. So it basically causes a disruption of the axonal transport. So the microtubules which are there in the axon, which disrupts there, and that is how your action potential or your pain sensations transmission is disrupted. It also causes axonal degeneration, or also causes direct damage to the DRGs as well as the mitochondrial dysfunction. It causes. If you see, there are various group of drugs which act at various levels. For example, if you see bortezomib, it causes proteasome inhibition. If you see cisplatin, it causes induction of sensory neuron apoptosis. So various group of anti-cancer medications act at various levels. So what are the features? The particular feature is that the patient has polyneuropathy with symmetric stop glow distribution. So this is very, very important. The patient has a symmetric stopping glow distribution of the pain. It usually starts with the tip fingertip. Mostly in the lower limbs, it starts from the lower limbs. Sometimes in some group of patients, it will start in the upper limbs, but ideally speaking, it always starts with the lower limbs. So it is the fingertips and the toes. That's the earliest symptoms which it develops. But there is a lot of problem in measuring this type of neuropathy, because most of the patients do not say that it is a pain. They will just say that it is some uncomfortable sensation. So that is how we just can't pick up this group of patients that they are suffering from something called as CIPM. So that's why it is very difficult to identify this group of patients. And they consider, some patients do consider it as a minor problem because they think that cancer itself is a big thing. So this is just a minor thing, we just ignore it. So just that ignorance is there. Then there are not very easy tools or comprehensive tools have not been developed to diagnose this condition. And it is limited because toxicity is determined subjectively by the healthcare provider. Because if the patient says and the healthcare provider has to accept it, so most of the times it is just the negligence from our aspect also, because we will say, itna to hota hi hai, it's okay, nothing to worry, aapka cancer to theek hai. So that is how it happens. So there is a diagnostic criteria which has been developed way back in 2017, and our very own IIS President Judith Paez has written this article very well. And there are 6 factors in this in criteria by which we can diagnose that the patient is suffering from CIPM. One is onset of the pain after exposure to the chemotherapeutic agent. Second is that there should be an asymmetrical stopping and glow distribution. Third thing is that there should be accompanied by non-painful symptoms like pins and needles or numbness. Then clinical examinations should reveal one or more positive or negative sensory findings in the form of hypoesthesia or hyperalgesia. And the magnitude of sensory abnormalities should be disproportionately greater than the magnitude of any motor abnormality. And last not the least is no other condition should account for this kind of symptoms. For example, we call it as a diabetic peripheral neuropathy. So we have to rule out that things. And there are various gradings. I'm not going into the details. Gradings are in the form of motor grade, sensory grade, pain grades. In our institute, most of the patients who are suffering from grade 3 and on come to our pain clinic. But grade 2 and grade 1 are they just managed by vocal or by consultation with the nurses, pain nurses. So how do we manage? Now there are various trials which have been done. So now there are 2 aspects to the management. So we always discuss something called as non-pharmacological and pharmacological, but in pharmacological management, again, there are 2 ways. There is something called as preventive management of CIPN, and there is something called as treatment management of CIPN. And if you see, there are various studies which have been done, all randomized controlled trials, and most of the trials are done on vitamin E, calcium, magnesium. Vitamin E has shown some positive, but the meta-analysis which was done way around in 2013 and all showed that it doesn't have any positive outcome. Okay, so that's how regarding calcium, magnesium, glutamine, glutathione, none of them had shown any significant prevention of CIPM. Even if you see amifostine, nimodipine, all these medications are not effective. Coming to the random controlled trials for the treatment of CIPN in the form of amitriptyline or amitriptyline or gabapentin and lamotrigine, no CIPN. So, and if you see, these are all placebo-controlled double-blinded trials. These are not a simple observational studies or a single-arm trial. there are double-blinded crossover trials. So none of them are shown. So they are very high level which are shown. But there is something help the patient in a very good way, and that is that we have to always maintain the temperature, water temperature. It should not be hot, because if the patient his hands into that, he may have burns. He should always use protective gloves while washing dishes. Even while traveling, he has to put on protective gloves. He should use pot holders. Suppose if you want to drink a cup of tea, just can't hold the cup of tea directly. He has to use something called as pot holders, or he should wear cotton socks. Then you should have a well-lit rooms without glare, then clear walkways and non-skid showers by installing.
போடா போய் வாங்கி வாடா. ஏன் நீ சொன்ன பேச்சு கேட்க மாட்டேன்ற? நீ போப்பா, என் பேக்ல இருந்து காசு எடுத்துட்டு போய் வாங்கிட்டு வா. செல்லு வாட்சுக்கு போடுற செல்லுன்னு கேட்டு வாங்கிட்டு வா. Lakshmi store la poi vainu va.
Anand, can you mute everybody else, please?
Yeah, just a second.
Yeah.
So, okay, can I go ahead? Okay. So,
please.
There are certain recommendations by expert groups, and one of the most important group is that ASCO group, the American Society of Clinical Oncologists groups. And if you see this, for the prevention of CIPN, they should not offer any of the following agents. So, none of the agents should be given for the prevention. And for the treatment, no recommendations can be made for tricyclic antidepressants, gabapentin, also including amitriptyline cream or that ketriptyline cream, which is available in India. That is the combination of amitriptyline, ketamine. Okay, even that cream is also not recommended. And they say that there are no agents recommended for the prevention of CIPN, but they support a moderate recommendation for the treatment of duloxetine. So even the NCCN says that there are nothing treatment. So what we do is that almost less than 5% of the patients are in grade 3 and 4 who present to our pain clinic. And if only sensory symptoms, the dose reduction is done by 50%. And this is in concurrence with our medical oncologist. We speak with them, and we just tell them that the patient is having grade 3 or 4 type. And I think if it is a feasibility, can they do that? And this is the first thing they always do, that the dose reduction by 50%. If there is motor involvement too, then they usually stop it and they consider a lesser neurotoxic agent. And at pain clinic, we start them with TCS, though there is no recommendation, but we are left with no choice other than these two group of medications in the form of either amitriptyline or nortriptyline based on the patient's comorbid conditions, or duloxetine. And we counsel the patient by our pain nurse. Coming to the radiotherapy-induced oral mucositis, it is a very significant problem for solid tumors. Specifically, when we are giving chemotherapeutic agents for solid tumors, it is a common problem, and almost 50% of the patients who are having solid tumors or lymphoma, they do develop oral or GI mucositis. And patients with radiation therapy for head and neck cancer patients, especially, it is not the patient. If you are giving a radiation therapy to the lower limb, they will not develop the mucositis of the oral cavity. But if you are giving radiation therapy for head and neck cancer patients, they do develop almost 50% of these patients do develop oral mucositis. And the incidence is especially high in primary tumors of the oral cavity, as I already told you, oropharynx and nasopharynx. Those who are receiving concomitant chemotherapy, those who are receiving a total dose of 50 grays, I had already specified this in my previous slide, the second slide, and those who are treated with altered fractioning radiation schedules. For example, if the patient receives radiation treatment, more than one radiation treatment per day, the chances of development of this are too high. And these are the chemotherapeutic agents which do cause mucosal injury. So if you see the doxorubicin, cyclophosphamide, 5-fluorouracil, paclitaxel, vincristine, vinblastine, these are the group of agents which cause oral mucositis. And this is how is a 5-stage model for the development of oral mucositis. So what happens is that initially there is an initiation. Okay, now the strands of the DNA and the basal epithelium are affected, and then there are free radicals, the reactive oxygen species are released, and then second stage is that there is an upregulation process, and then the signal amplification, ulceration, and healing. So this is how is a 5-stage model for development of the oral mucositis. And this is the WHO grading of oral toxicity scale. So usually grade 1 and grade 2 doesn't cause much significant effect in the patient's lifestyle. But it is the grade 3 and grade 4. If you see, the patient cannot swallow. So this is where the role of managing the pain comes. So this is where we play a major role. But before going to that, you have to always remember that there is something to the oral mucositis. It may not be always because of the chemotherapy or radiation related oral mucositis. We have to rule out other differential diagnosis in the form of aphthous stomatitis or herpes mucositis or oral thrust because of that fungal infection, or it is an acute necrotizing stomatitis. So because the therapy is very different and these are all treatable causes. So that's why it is very important to differentiate other conditions causing oral mucositis. The symptomatology is the significant primary symptom is pain, and it affects the nutritional intake, mouth care, and the quality of life of this patient. So thus the management of mucositis pain is very important, and many centers use mouth rinses. They use ice chips or topical mouth rinses containing anesthetic solutions such as 2% viscous lidocaine, or they use something called sometimes diphenhydramine and a soothing covering agent in the form of honey, and many such things. Always remember that don't use acidic components, or don't use chlorhexidine once, even for the prevention and even after development of the oral mucositis. So this is a strict no-no, because most of the patients do use chlorhexidine. So they think that it is an antibacterial and it will prevent the secondary infection. But I recommend that it should not be used because it causes or increases more pain and it damages more. And most important thing is that you have to give a good oral care. So good oral care in the form of rinsing the mouth 3 or 4 times a day by non-irritating solutions. You can use just a plain saline. What happens is that when you use this rinsing solutions, it stimulates the secretion or the quantity of saliva formation. Then if the patient wants to brush his teeth, you have to advise him to use ultra soft tooth bristles brushes, and you have to advise him that you should use a fluoride containing toothpaste. Okay, not our regular Colgate. Okay, then the diet should be very low sugar diet and non-acidic food and drinks. Smoking is strictly no-no, and alcohol is also strictly no-no in these patients. And these patients, even flossing should not be advised because most of these patients are on chemotherapeutic agents and the platelet count is low, and then there are chances of bleeding and all such things. So that's why this is are the points of a good oral care. So this is what should be suggested to these patients. So good oral care, that is what I was talking about. But as a pain physician, what other things which can? Good oral care is always advised by the primary physician. But as a pain physician, what we can do is that most of the patients, I had seen patients who are admitted in ICU. So such severe is their mucositis grade 4 that they just can't take anything orally. So we need to initiate, and I had initiated in many patients IBPC of morphine in these patients, and it has a wonderful results, and it gives a very good results and very good pain control. You can also try transdermal fentanyl 2% morphine mouthwash or doxepin mouthwash. I have not used this, but what I usually do is we use a IBPCA in the morphine and either a transdermal fentanyl. But if you see, the level of evidence is better with only IVPC compared to the transdermal fentanyl. And this is what the magical mouthwash which we use in our institute, and our magical mouthwash contains 500 ml of normal saline. Then we have syrup Benadryl 50 ml we add into that, and the Lox 2% 50 ml we add, and syrup Gelisil 50 ml. So this is a mixture. We make it and we give it to the patient, and they gargle it and they throw it out, and this gives them a good soothing relief and pain relief. And we can modify this magic mouthwash by adding 10 milligrams of morphine to it. I don't know how it acts, but we had seen maybe because of the systemic absorption of morphine through the mucosa, maybe there is no local action, but I think it is a systemic action which causes. And this is what it forms a modified magic mouthwash. Coming to the radiation-induced neural injuries, if you see, I have highlighted this. This is a late radiation toxicity. It doesn't cause immediately. It usually happens almost after 2 years or after 5 years of initiation of a radiotherapy. So it is never an immediate effect. It is always a late manifestation. And the classic example is the brachial plexus neuropathy. If you see, most of the patients who are coming for a CL lung of the patients who are exposed for radiation, brachial plexus neuropathy is to always keep in mind in the later phase of his life, because you see the CL lung patients, the survival rate because of many immunomodulators and immune check inhibitors, durvalumab and other group of medications, it has improved tremendously. The survival 5-year survival is almost increased up to 50%. So they may present with this brachial plexus neuropathy, and majority of the symptoms are ipsilateral, upper extremity, which includes paresthesia, motor weakness, pain, edema. And the process, it usually there is an intraneural and as well as an extraneural fibrogenesis driven by ROS, which we had already spoken. ROS is the main thing in the radiation, and then there are pro-inflammatory mediators, and this subsequently results in demyelination, direct axonal injury, nerve ischemia, and which causes a decreased perfusion from the microvasculature, and then there's an ischemia of this nerves. So that is how the damage happens. So this diagram in short explains everything. So there is an acute inflammation because of that exposure. So here the steroids have a very good role. If you are giving steroids at phase of acute inflammation, then the chances of normal healing are much faster. Then there is chronic inflammation. So acute inflammation sets in from days within weeks. Okay, so when they are starting, and if you are giving for upper lobe radiation, you have to always think that the patient may land up with brachial plexopathy. So it's better to give a shot of steroids to these patients, a course of steroids rather than a shot of steroids. And then it progresses to chronic inflammation, fibrosis, fibroatrophy, necrosis. So once the fibroatrophy sets in, then it becomes an irreversible cause. Then you just can't get back to the normal neuronal structure. So it is important to consider and exclude the presence of malignant invasion. So you would always think there's something called as Pancoast tumor. Everyone might have heard of this terminology. So it is very important to distinguish whether it is the radiation-induced brachial plexopathy or it is because of the malignant invasion of the tumor itself. The tumor may be the upper lobe, or sometimes the lymph nodes may be just coming and encasing the brachial plexus. So how will you distinguish is that usually the radiation-induced plexopathy is the upper trunk, and if you see the malignant invasion of the brachial plexus is the lower trunk. So by the dermatomal distribution itself, we can make out, oh, maybe it is because of the radiation, or maybe it is because of the tumor invasion itself. And also the time scale of onset. If you see it is a late onset, the radiation-induced neuritis or a neuropathy or a brachial plexus plexopathy, whatever you can call it as, it is almost a 1 to 10 years life span. But the malignant invasion is very fast. Okay. So this is how you can find out. And also you can see that there are cutaneous radiation changes as well as lymphedema in radiation-induced brachial plexopathy. So the RAPN is a treatment, that is the radiation-induced peripheral neuropathy. The treatment is symptomatic, and the best approach is always prevention. And how will you prevent? By reducing the total dose, or you can increase the fractions by reducing the RT dose. That is what you can do. And we can give non-opioid analgesics, tricyclic antidepressants, anti-epileptics. Then we can advise them to do certain occupational therapy and physical therapy exercises. This is very important, controlling acute inflammation with corticosteroids. So this is where I was talking to you about, and in the chart also I have shown you. So if you are just giving steroids at that particular time, right time, then the chances that the inflammation may not progress, and we can control that inflammation with steroids. There is no benefit with an hyperbaric oxygenation. There are certain studies which have shown that the pentoxifylline and tocopherol combination may reduce the radiation-induced fibrosis because of the synergistic clinical and biological properties. There are just certain observational studies, and the studies are still ongoing. So we really don't have any results in our hands. So at present, the literature doesn't recommend, and even I have no personal experience using pentoxifylline and tocopherol. Coming to the head and neck osteoradionecrosis. So it is because of the head and neck radiation, and it is a very serious condition and a painful condition. What happens is that the bone gets exposed, especially the mandible, when you're giving for a cerebral mucosa patient or any even tongue patient. So the major risk factor includes radiation doses greater than 60 grays. So if you're using the radiation dose more than that, the chances are high. If the dental extraction has happened, then the chances are high. And also if the patient, we are putting a brachytherapy, then the chances are high. So this is how it is, and it usually the onset is also again late. It is between 2 to 5 years period of the radiation exposure to the patient. And there is a classification. There are various classifications which are described for ORN, that is the osteoradionecrosis, but the commonest classification is by the Marks, and he has described in 3 stages. The first stage is exposed alveolar bone without pathological fracture, which responds to hyperbaric oxygen therapy. The second is the disease does not respond to that HBOT and requires sequestrectomy or saucerization. And third thing is that just take out the bone, complete resection, and do a construction with the free tissue. And this is the treatment which we can do. So conservative treatment in the form of oral hygiene, improving minimal surgical debridement, HBOT, And pentoxifylline tocopherol again had shown that it also has certain role over here because of those biological factors. It reduces the fibrogenesis, it decreases the pro-inflammatory mediators. That is how it acts, and that is how it can help. Surgical treatment is in the form of sequestration, osterization, segmental resection, and flap reconstruction. Now is the last slide of my presentation, coming to taxane-induced myalgias. So this is what I was talking about. We speak about. So this is an acute pain which is associated with taxane therapy and starts immediately within 24 to 48 hours. It is not that you have to wait for a week or so. It immediately can start. And most commonest drug that the taxane is the paclitaxel. When you give, the patient has a severe pain in his legs, especially the calf muscles and all. It is a very achy pain or myalgia, you can call it. And patient also sometimes may present or does not present with arthralgias. There are no clear definitions or standard tools for assessing these TAPs, that's taxane acute pain syndromes, and the risk factor also not well established. So what are the treatments for these TAPs? Is you can give gabapentin, or you can give ibuprofen, NSAIDs, or oxycodone, though it is not available in India, but still we can try with morphine or some other group of opioids. Prednisolone we can use in this group of drugs. And with this, I have finished my presentation. Thank you very much.